Good afternoon. Welcome to today's webinar. My name is Dina Johnson, and I'm the Training Co-Director for JFK Partners at the University of Colorado School of Medicine. JFK Partners and the Colorado Title V MCH program collaboratively present a quarterly educational series to address the current Colorado Title V MCH priorities and emerging issues. This series is intended to expand the capacity of the maternal child health workforce and related systems to better serve infants, children, youth, including those with special health care needs and their families. Feel free to type questions or comments in the chat box at any time. Please be sure to mute your microphone so we don't hear background noise, and stop your video so we only see the speakers. We are recording today's event and will archive it on the JFK Partners website along with the other webinars in this series. We are posting the handout for today on the same page where the archived video will be, so you are welcome to print and save for future reference. Following the webinar, you will receive a link requesting an evaluation. You may request a certificate of attendance in your evaluation. Today's topic is improving access to services to identify and manage children with autism spectrum disorder and other developmental disabilities. Our speakers include developmental pediatricians, Dr. Sandra Friedman and Dr. Ann Reynolds, and psychologists, Dr. Rebecca Wilson and Elizabeth Cohn, all from the Children's Hospital Colorado Department of Developmental Pediatrics. So I hand it over to our speakers.
Okay, so this is Sandy Friedman. Thank you all so much for signing up to join our webinar. Anne, Rebecca, and Liz and I are very excited to tell you about some of the new initiatives that we have been doing over the past year and a half. And at the end, you'll have opportunity to ask us questions through the chat box. And so Dina already told you what our topic is. So Liz, do you want to go to the next slide? And none of us have any financial relationships, unfortunately. So for the objectives for today is to recognize the barriers to obtaining comprehensive diagnostic assessments for children with complex developmental and behavioral profiles. We hope to describe different models of care used to increase capacity of primary care providers to manage children with autism spectrum disorder and other developmental disabilities, and demonstrate an understanding of the purpose and practice of ECHO to support the management of children with autism, developmental disabilities within the context of their medical home. So everybody I know who was on this webinar is very aware that the prevalence of autism has increased markedly through the years. I remember when I was in training, it was like 1 in 2,000, and so I'm dating myself, but now nationwide it's 1 in 59, and in Colorado it's 1 in 72. So we definitely have seen an increase in prevalence and an increased need to address the needs of these children, youth, adults, and their families. Next slide. So just to give a little context about Colorado and its children, so everybody is aware that the state is divided. There's a Front Range and the Rocky Mountains, and there's a big disparity in services and access to services to people in the Front Range compared to people outside of that area. There's also not enough providers in more remote areas of the state, all different types of providers, primary care providers, specialty providers, and in the winter, it's quite hard for travel. So I care for some families who won't come in the winter months because they don't want a chance being in the middle of a snowstorm. So it's difficult. In Colorado, in the 2016-17 survey, it was found that 87% of the population resides in the metro area. 6% of children live in rural regions, and 3% of the children live in frontier regions. Next slide. Also, in the Health Access Survey, they found that about 1/3 of children and youth with special health care needs were unable to get timely healthcare provider appointments, and 38% said they weren't able to obtain transportation, or the office to their provider was just too far away for them to travel. Going to developmental pediatricians, just so that you have a feel for what's happening in the Rocky Mountain region as well, and also including North and South Dakota, because we often will see patients from those states as well. There's really a paucity of board-certified developmental behavioral pediatricians. In December 2017, there were none in Wyoming or North Dakota, 1 each in Idaho and South Dakota, 2 in New Mexico, Montana, and Utah, 3 in Nevada, and 10 in Arizona. In December 2017, there were 14. Actually, now there's about 7, because some people have moved away, some people have retired. So there's approximately 7 now in Colorado. And so based on the number of children in Colorado who may need a developmental pediatrician, that's about 90,000 children per specialist in 2017, and now it's even more in 2020 when we have less developmental pediatricians in Colorado. Just to kind of put it in perspective, this is not just a Rocky Mountain or Colorado issue. This is a nationwide issue. There is a national shortage of developmental pediatricians. The average wait time for a family to see a developmental pediatrician for a comprehensive evaluation is almost a year, 327 days. And autism is no longer a rare condition, and that always demands specialty care. And we really identify the need to expand our reach. We can't just depend on developmental pediatricians to provide care to every child with developmental issues. There are long wait lists, not only in our program, which we're going to talk a little bit about what we've done to try to decrease our wait list, but this is a national issue. There's not enough providers to meet the needs. There's open physician positions for developmental pediatricians. I always say that not truly, and this is literally, not a day goes by where I don't get an email, or maybe with the coronavirus, maybe not every day now, but pre-coronavirus, every day I would either get an email, a voicemail, or a regular piece of mail that tells me about open positions. Do I know anybody to help fill them? So we really decided as a group, we need to reevaluate our models of care, because we can't keep operating the way we have in the past.
So this is what we in developmental peds face every month. We have had a very consistent range, a very consistent request for our evaluations. We get about 300 referrals a month. That doesn't vary very much, and we can do about 200 evaluations a month, and that's in a perfect month. That's when nobody takes a vacation, nobody goes anywhere. We can do about 200 a month. So this isn't just a press for our services, it's a tsunami, and we get farther behind every month. And it's for this reason that we really wanted to look at a different way to manage this demand. So we figure we've got to figure out how to surf this wave and not be drowned by it. And so what we are about to present to all of you here are the care pathways that we've put together to meet what we can of this demand and really manage it in a different way than just bring all the kids into our academic medical setting and see them all for an evaluation. So this is a pictorial of the different care pathways that we've put together within developmental pediatrics. And the image here really is meant to capture how we're working from within the academic medical setting all the way out to our rural and frontier communities. Now, I want to make the point here because we're going to go into each of these individually, but these look like individual pathways. They really are integrated pathways and inform one another, and we use the different pathways to support the other pathways. At the very bottom, the initial assessment model is what we're doing within our academic home, and then all the way out at the top, that's what we're doing out in the community. So that's our real outreach model. And now each of us are going to go through these different pathways and talk in a little more detail about what we've done in each of these areas to improve care for the kids we see. Anne, did you want to talk about this one?
Sure. So we have outreach clinics that we've been participating in. We had an outreach to Edwards and to Rifle, and then we went to Durango and had and were there for 2.5 days and saw quite a few patients. And what's been great about it is the PCPs have been able to join the visits and like watch the ADOS on a patient that they referred, or participate in the feedback. And I think it not only does it coordinate care better, but it's also an opportunity for learning for the PCPs. And so it's been a wonderful collaboration with them. They've all been amazing. And we're hoping, well, we were going to go to Montrose and then hopefully Glenwood, but now we can't travel, so that's all on hold. But more to come. It's been
if I can just add here, it's obvious, I think, to all the to everyone in the webinar that we are mostly focused on the Western Slope at this point. These are the partners that have really been actively reaching out to us, and we are looking forward to building outreach clinics out on the Eastern Plains, which is our next frontier, if you will.
Great. So I'm going to talk a little bit about one of our specific efforts, which is a collaborative effort with developmental pediatrics and our partners in the Pediatric Care Network, which is actually a program that the hospital put together with affiliated partners in the community of primary care practices. So I just love this image here of us all putting the kind of puzzle pieces together, because I really do feel like this program has been an example of what true collaborative care looks like. And so instead of thinking about what the PCPs are doing in their home and then what we're doing at the hospital, really thinking about how we can partner more truly. And what we've begun to design is evaluations that really start in the PCP's office and then are finished in our specialty clinic. So just a little bit of information about the Pediatric Care Network. So I think right now there's 33 or 34 practices across the state that are affiliated with the network. As part of this program, they're connected to children's hospital specialists and educational programs. And our autism initiative was an educational program that began in 2019 in working on developing educational services for the PCPs in the community, but also ways to partner, like I was saying, in the evaluations. Oh, and this is a use your imagination slide because we had some graphic translation issues. But similar to the outreach slide that Anne was talking about a few minutes ago, This is just kind of a representation of where the different offices are across the state that are participants in the pediatric care network. And you can see how many practices this covers, how many physicians are a part of the network, and then how many advanced practice providers. And also there's some information there too about what percentage of patients belong to the Medicaid community, which is also something that's been a huge focus of our outreach programs as we've developed these 8 pathways as well. So the model that was designed to kind of launch the autism program within the pediatric care network, here we kind of highlight 5 steps of this program. But essentially this program starts with the psychologist, me, going out to the physician's office and providing some in-person education about identification and assessment of autism spectrum disorder. Depending on the practice, there's anywhere from like 2 to 4 in-person educational sessions. And a lot of that depends on the practice's preference in terms of like getting all the education at one time or spreading it out. But some of the things that we really focus on are that review of the diagnostic criteria for autism, an educational session on how to speak to families about these developmental concerns, which is really a difficult thing that we do all the time in our clinics. And then most importantly, we do a training on how to perform a autism-focused developmental history with the family. And so this is a big bulk of our assessment when families come in to be evaluated in our unit. And so essentially we're asking the PCPs, once they've completed this training, to do this beginning of the evaluation in the office. So they are conducting that autism-focused developmental history, and they are introducing the idea of autism or other developmental concerns to the family so that these families are really well packaged by the time that they come back in for us to finish the evaluation in our clinic. So the practices get those developmental history templates that we've developed for them. They begin the evaluation in the office. Then the patient, once that evaluation is complete, they're expedited to DP, developmental pediatrics, for us to complete the assessment. And then one of the things that has been a great addition to this program is that once we finish the evaluation in developmental pediatrics, we provide personalized feedback to the PCP about their referral. So just like you noted in your history, I agree. I also saw lack of eye contact. I also saw difficulty with social reciprocity and conversation. I agree with you. I saw those things as well. Some things that maybe you didn't mention in your history that I thought were notable were this, this, and this. And so we are kind of creating a continued partnership where we get to provide that feedback and hopefully see refined referrals coming into our department, but also the possibility of down the road really encouraging our partners to feel confident that they are recognizing autism in their office and perhaps feeling confident enough to make that diagnosis in their office instead of referring them for a full evaluation when maybe that's not needed. And then the newest addition to the program is that, of course, once the evaluation is completed, we then refer the family on for appropriate next steps. So that would be a meeting with our resource team, possibly an appointment with a nurse practitioner or one of our developmental behavioral pediatrician fellows, and even therapeutic services as well. So once they're connected through the program, they have the opportunity to follow through with other services as well. So this data is a little outdated though with COVID descending upon us. I mean, how many, we should have like a tally or something for how many times we have to reference that during today's presentation. But so there's the statistics that we have through kind of the first month of 2020 is that 12 practices out of the 33 in the pediatric care network have completed the training. That consisted of about 40 in-person educational training sessions of me going out to various offices. But over 100 providers have been trained in this program so far. And so obviously we have a lot more practices to get to, but it's exciting to think of how many providers will be trained once this is complete. Again, a little bit outdated here just because we've done some more evaluations since our January date here, but there were about 30 evaluations completed in developmental pediatrics that were direct referrals from the PCN program. And the kind of some info there about the average age and presentation of what we were seeing is there as well. We saw our youngest kid was 23 months referred through the program and oldest was 17 and a half. But kind of the most exciting news is that 71% of these referrals resulted in a confirmatory diagnosis of autism. So thinking about, you know, is this education working? Are we kind of recognizing the same thing as autism? We're seeing some really promising results. But it's a difficult statistic to really talk about accurately, because I just want to add that there are lots of really good referrals that come in to see us that do not end up with a diagnosis of autism, and it doesn't mean they shouldn't have been referred. But it is exciting to see that we seem to have pretty good agreement between what we're recognizing as autism. And then just a little bit of feedback that we've begun collecting from the program. I won't read these out loud for you, but kind of generally speaking, the providers have been really happy with the program and enjoyed the education. And I hope as the program develops, we'll be able to have some more kind of hard statistics about those confirmatory diagnosis rates. And then also some additional information maybe later about, you know, are we not seeing as many referrals from certain practices because they are more comfortable managing these diagnoses in the home? I think that'll be exciting to kind of look for in the future.
So I'm just going to talk briefly about another initiative that we started last summer. And it's not only developmental pediatrics. This was rolled out to many different subspecialties within the Department of Pediatrics. So we are now doing e-consultations where we developed a template for primary care doctors to ask focused questions about patient management, and they don't have to be affiliated with our practice. They just have to have access to e-consults. And these are primary care providers who use Peds Connect, which, you know, our electronic medical record is Epic, and the hospital provides Epic to a number of different primary care practices. So these right now are for primary care practices that share Epic, because they send an e-consult directly to us with specific questions about med management, diagnosis, other things. And so they ask a question, and then we respond with guidance in terms of management. And we actually are able to bill for this. The university is supporting this right now. And so we haven't been flooded with these, but they actually have been very well received. And initially they started in the child health clinic at Children's, which is a primary care clinic where residency patients, and it's gradually expanded to 18 practices. And again, because COVID, it's stopped expansion, but I anticipate it will continue to expand to other practices as well. Okay. Next slide.
So we conducted a training for primary care providers on the STAT, which is a second-line screener for children between 24 and 36 months, although you can go down to 14 months and up to 48 with some modification in the scoring. And the test itself differentiates kids who are at risk for ASD versus just having a developmental delay. So, so it's meant to be used in kids who have DD to separate, you know, to say this is the kid with higher risk for ASD. So it's not a diagnostic tool. It's not the same as an ADOS, but it is an opportunity for the primary care clinician to interact with the child face to face rather than using a questionnaire. It takes about 20 minutes to complete. You can bill for it at a higher level than screening tools like the MChat. And then you also can, it doesn't have to be a medical provider. Other people can be trained on it as well. So we started with a small number because we were just piloting things. We had a pilot grant from Autism Speaks. And so we trained 11 practitioners representing 8 different practices on the stat. And we then we'll talk about how we integrated that group into our ECHO process. But we saw that about a 70% increase in stat use from baseline. And we are planning a stat training in May with Wendy Stone, who's the developer of the stat. We're hoping to turn that into a virtual training, but we're working on the logistics of that right now, but we're super excited about that. So our ECHO program is something that we feel like has really been, it's been an amazing experience for us because we really have been able to interact with primary care clinicians and work as a team to come up with a plan for very difficult issues that may not have an obvious solution. So our first ECHO was a total of 8, 4 from rural and frontier, and 3 from underserved populations like Denver Health. And so then we kind of supported them with use of the stat. We also did some training on different areas, such as like, I think we did sleep and toileting. And so that was wonderful. And many of those converted to our community of practice, which is an ongoing once a month opportunity for us all to interact and share cases. And so, I mean, it's been great because, you know, different providers in rural areas know about things that we may not know about. And so it's just been wonderful. Our second cohort was quite big and probably a little harder to have a lot of group interaction. But we had 9 from rural and frontier and 10 from underserved. And so they've all been well attended. You know, you always worry maybe you'll get a lot of people for the first one, then they'll drop off. And we really didn't see a drop off. Then the third cohort was 16. And so again, we are trying to encourage rural and frontier communities. So for those of you who are in rural or frontier communities and you know a provider who might be interested, please let them know about this. And so we're currently doing our 4th. And the community practice has been, a community of practice group has been going since last year.
And if I could just add, in these ECHO sessions, there's a brief, like 15-minute didactic, and the rest of the session is reviewing of a case, ideally from one of these practices where they have a diagnostic dilemma and they want to have input from the group, which the group consists of Anne and myself and Rebecca and Liz, as well as a social worker, a nurse care coordinator, and now a genetic counselor. And so we provide input to them about, but we also try to elicit them to contribute their experience, and we really learn from each other.
Yeah, just to echo about the ECHO.
No pun intended.
It really has been such a fascinating collaboration because I think sometimes the idea, right, we're there providing didactics, but I really, that point about how much we learn from each other is so important, especially because, you know, our social workers and our resource team works really, really hard to make sure that they're maintaining their contacts with various service providers across the state. But no one knows better than the people who are living in those communities about what's really going on. And so we constantly get updated information about what those services look like. And some of the cases that are brought to the experts, I'm still up at night thinking about them because they're really, really difficult cases. And so it is an opportunity for all of us to learn, put our heads together, and think about what kind of like multifaceted care looks like for these kids.
And adding on to that, because we're all echoing here, you know, the other really positive part of ECHO has been to see the providers connect with one another and learn about resources that are in their area that we weren't aware of. The other thing that I think it has educated us more about are the challenges that rural, frontier, and underserved communities are really struggling with. We have families who they have one car and the father does landscaping, and literally there is no way for the families to come in for evaluations, or can't get to ABA services because the family has no transportation to do so, or have to go through Glenwood Canyon to get there. So those are the kinds of things that have been so powerful in the ECHO, and also helped us feel more connected with the providers that we're working with.
And ECHO, the acronym, it stands for, I think, Extension of Community Healthcare Outcomes.
And yeah, and it's available for all kinds of different trainings. So, so the next thing that I was going to talk about is the case presentations. And this chart is actually a little old, but you can see that we were reviewing cases from all over the state. We still need to work on the Eastern Plains, but we feel like we have a great representation from some providers on the Western Slope. Super engaged, amazing clinicians. So, and I think everybody pretty much commented on how those go. And then this was just kind of providers talking about how comfortable they felt like discussing an autism diagnosis, and all of these changes were statistically significant. So the provider testimonials actually line up with what we were all saying. And so, you know, networking, feeling supported, not just by us, but others who are in the similar boat. And then, you know, kind of gaining information about what other people are doing. And they also felt more comfortable helping families with sleep and feeding issues. And then I think these are really nice. These are changes that they were planning to make. One was more consistent screening, better teaching points for parents on anticipatory guidance, more routine follow-up, like maybe seeing the kids every 3 months, and then changing how they use medications for things like ADHD and kids with ASD. So we really felt like it's just been an amazing experience. So you can go ahead to the next one. Rebecca?
So telehealth, oh my goodness, telehealth. Telehealth in the age of COVID is a whole new world for us. We started doing weekly telehealth initial assessments through telehealth, and this was a beautiful model. It again kind of dovetails with some of the things we're talking about, because we could provide some telehealth assessments for families to make certain that it made sense for them to come in for a full evaluation. And we've been doing those weekly for over a year now. In February, we were able to start providing in-home telehealth assessments, initial assessments, and that has been very, very successful and very appreciated. There are always some barriers with bandwidth in rural communities, but it's not as big of a barrier as we thought it would be. At the beginning of this month, we started instituting MD follow-up visits, again in-home, which has been an enormous advantage for families who can't travel with kids who are really impaired. that alone has been, I know, huge for some of our families. And guess what? We are expanding telehealth significantly just in this week alone. I think, I'm not sure what our exact numbers are in developmental peds, but we have significantly increased our telehealth in developmental peds. At the beginning of next week, we will pivot almost all of our clinics, or as many as we can, because families have to be within state, and there are some other barriers that we have to take into consideration. But we'll pivot as many clinics as we can to a telehealth platform. And this is going to continue. We're going to continue to do telehealth, and we're looking at very innovative models for being able to provide more telehealth for our families. And they really appreciate it.
Yeah, and one thing that we have found, we thought wouldn't be successful, but has been, is team evals, right, Liz? Or not team evals, group sessions.
Yeah. Yeah. So of course, just going back, let's see. Of course, we had these models in place kind of before COVID descended upon us, but we really are like ramping up our services. So this has been successful. A lot of individual therapy patients have been translated into telehealth. Group therapy has been translated into telehealth with some significant adjustments in terms of how long our guys can sit in front of the screen sometimes, especially after they've been in virtual classes all day long. So we are learning as we go. But we're excited to roll out, like Rebecca was saying, some new programming where we can at least perform some consultations with patients who were scheduled to see us in person and get done bulks of the assessment, and hopefully still connect them with resources so that we're not kind of wasting time as we all are navigating the state of affairs right now.
And one of the advantages of this, I think Liz can speak to as well, is we offer an ABCs of behavior for parents. And being able to provide that in a Zoom platform has been really well received, and we will expand that model significantly.
Yeah, this is kind of the dream model for telehealth because it's a group that parents attend without their kids. And so we're able to talk about behavior management strategies and problem solve. And we've offered this group in person for years and years and years in developmental pediatrics, but have always been kind of trying to make that switch so that we can reach some of our more rural communities and still provide this service. And so what an opportunity to do so. So those groups, I think, are starting up via telehealth as soon as next week. I know my next one is starting the following week, but we are in it for sure.
Yeah, there was just a question about what are we doing for initial assessments. So the initial assessment model is basically interviewing and maybe observing the child somewhat. We're really struggling with how do you evaluate social interaction virtually, but we are thinking about models to do that, where the parent would actually kind of give a mini ADOS, Autism Diagnostic Observation Schedule. So yeah, more to come on that. But we're at least getting the process started for these families so that we can fast track them after we can, open up our ambulatory clinics again.
And just adding on to that, we also are doing some standardized assessments. For example, the Basque and the Vineland can be provided to parents through a link. It allows us to have a very focused evaluation at the close of COVID so that we can bring them back just for the pieces of the assessment that we need to do in person. So we are trying to think very broadly about what else can we do, what else can we provide. Families honestly just are relieved to have a chance to talk things through with us. And as Anne pointed out, just gathering the developmental history is a big part of the assessment. And we can easily do that on telehealth with families, in some ways even more easily than we can do it in the room when we're trying to manage a child in the room.
And the initial assessment model, even before, and we'll talk more about it at the end of this presentation as well, but before the the translation into telehealth, the way I think about it is kind of like a personal triage, you know, so that you're really getting to know the family face to face. And a lot of times that initial appointment can help us direct families maybe to other departments in the hospital that are maybe the more appropriate place for them to be seen. So a lot of times it might be difficult to answer the question about, yes, does this child have autism after meeting them once? But sometimes you can answer, no, they don't, pretty quickly. And that allows us to get them connected with the other kind of departments within our community or within our hospital, and then services within our community that would be a better fit for them.
So this slide is just kind of a summary of some of the things we've been talking about that we've mentioned so far, but these are the in-clinic model improvements that we have instituted related to our clinicians' templates. We've looked at our templates very carefully to make sure we're maximizing their templates. We've instituted a nursing physician bookend that Anne will talk about a little bit more. And then we've expanded our clinic model to do the most efficient approach we can do within the clinic for our assessments. And then our initial assessment model, we keep using that term. This is a model, and I'll talk about it in a little more detail, but it's a model where we have taken our older patients and done an initial assessment to make sure that we really are focused on developmental questions, not psychiatric questions. And so we can do an initial kind of tease out for sending them on for psychiatric care if needed. And then Liz has been talking about the PCN model.
Okay, so you saw the slide on the nationwide shortage of developmental and behavioral pediatricians earlier in the presentation. And what we have been looking at is how can we help our developmental behavioral pediatricians and our nurse practitioners work at top of scope. And so the first thing we did was do what we call a nursing bookend, where the RN would help with pre-charting and other parts of the history, and then come in at the end to kind of help with any other things that the family needs before their appointment's finished. And you can see we were able to move a lot of issues over to the RN, and in the process of doing that, increase how many patients the pediatrician could see per session by at least 25%. And one of the most important pieces is without burning them out, because we have had 4 open positions now for a couple of years. And so this was really important. And then we decided to try to use this model more broadly in our team evaluation clinics to look at how we can shift some of the tasks so that the medical provider can see patients more efficiently and increase the number of patients they see per session by 50%. So it's been amazing, and I think the RNs have loved it. They've loved having more contact with the families, and so I think it's really been a rewarding process. And so now we're working to expand it out to the rest of the clinic, which will require more nursing support, and we're working on ways to do that. So, and just to kind of show how successful it was, the physician's time per patient went from 155 minutes to 74 minutes. So that was, you know, a 50% drop in time, which obviously frees the physician up for more other things.
So our initial assessment model, let me talk about this a little bit more. What we were doing was full assessments for all of our patients. If they were referred to us, we would do a full assessment. And we really, you know, the longer patients waited, the more we felt like we needed to provide a full assessment. We tried a number of different approaches for doing a really good screen initially to make sure that we were doing a right fit for evaluations. And we were never very successful at actually, and I use the word triage a little bit carefully, because it's not that we're not wanting to care for all of our patients, we do, but we want to make sure that kids get sent on to the right fit for whatever they're presenting with. So we instituted a model where the psychologist that was providing the assessment would do an initial assessment first, and then develop kind of a right fit evaluation for what was being presented. What this allowed them to do was to identify a significant portion of kids that really didn't need further evaluations. Sometimes these were kids that had already gotten full assessments in the school, but needed someone to interpret the assessment to the family. Sometimes they just needed our team to say, you know what, this is an appropriate diagnosis. You really don't need further diagnostic assessment. Sometimes families were just trying to get some resources and they didn't know where to go except for to us. So when we started this initial assessment model, we found out that for kids, and that's that big blue 36.5% bar, about 36% of our patients really, when they're 7 years old, really needed no further evaluation. Now you can see for the younger kids, the 5 and 6 year olds, almost all of those needed to go on for full evaluations, and that makes sense to us as well. They're really presenting with those initial developmental concerns. We want to make sure to do a good job of providing a thorough and gold standard assessment for them. For the older kids, and you see 11 and 12 and up, they all look like they need to go on to full assessments too. And that's because those kids are complex. And oftentimes these are kids that are getting a late diagnosis of autism that may have been missed before, or there's just considerable complexity and need for full assessment. But if you look at this graph overall, you can see that we've been able to make a significant gain in terms of moving kids on to more appropriate resources. Sometimes we just send them on to our social workers and our family navigator to help connect them with resources, rather than taking a clinician's time to do a full evaluation. And this is a good model of how we're trying to surf the wave, not be drowned by it. So what has this done for us? We're very fond of this graph. We all want to make sure you see this. We've been able to significantly reduce the wait lists for our school age and adolescent kids, and we've done this through this initial assessment approach. And in the initial assessment, you can see over on the left-hand side what we're able to do with it. And one of the biggest gains is just to right-size the assessment. So not every single kid gets the same assessment. And the psychologist that's providing the initial assessment is the one who, if you will, benefits from a right-size assessment. So they're not scheduled for a full assessment for every single kid, whether they need it or not. Just to kind of summarize some of the ways we've been able to improve access across our clinical services, we've seen an overall waitlist reduction of about 16% with some of these things we've just presented to you. Even though our referrals have remained steady, it's not that all of a sudden they're all going somewhere else. And this is in the context of losing a number of our physicians. We really think our interdisciplinary model is crucial. We would like to maintain it as much as possible, but we're doing the best in the context of still trying to fill some of these positions. And we continue to have a tremendous demand for our services, and our visits have gone up over time. So we still have some things that we need to sort out. We certainly want to track some outcomes for some of our new processes. And we are really looking forward to the telehealth innovations that COVID has blessed us with.
Oh, that's a nice way of saying it.
And you have to unmute.
Sorry. I was saying sorry to myself. So we recognize that while we may feel like we're surfing, we are just getting started. But we are planning to continue to work on having providers work at top of scope and to partner with community providers to manage children, more children with ASD in their medical home, so that we can finally get to the point where we really are surfing. Cue the music.
Sorry, I was too soon. I was so excited about it.
Okay, so we're a little technologically off cue, but Edward.
Better than me singing it, which was also an idea.
Yeah. But we're planning what we, a lot of quality improvement projects to be ongoing to help with access to care. And it's just been a great, we're gonna, a bit collaboration between all of our providers and our staff. So that's it.
And just to bring it back home, we know there's a lot more work to do, and we're not patting ourselves on the back by any means, because we still have a long wait list, longer than we want, even though it has significantly been reduced. We're expanding all our projects. We're trying to do more outreach clinics. We are hiring, we actually have 2 developmental pediatricians starting in September. We are expanding to Broomfield, to North. We were supposed to start in May, although I don't know if that's going to be set back a little bit because of COVID. We actually are going to have a presence, we're hoping in the 4th quarter of 2020, we will have psychology and developmental pediatrics down in Colorado Springs. There's a lot of, so we are expanding our clinical sites, we're expanding our faculty. The hospital has coordinated autism services that we've been on the forefront. So we're trying to develop a system for children with autism who may need to be seen by developmental pediatrics or psychiatry or speech or OT or a number of different services, have one port of entry. So they don't, because sometimes we'll see somebody ends up in neurology and the neurology sends them to us, or somebody comes to us and they really belong in psychiatry. And so what we are working on, and we've finished phase 2 pilot to make certain this will work, is to have a very comprehensive intake with social worker and family navigators to make certain children and youth go to the right provider at the right time without being bounced around. And it's been a wonderful collaboration with all the services in the hospital and the hospital leadership. And we're continuing our telehealth innovation. Just again, as I think Rebecca has noted, that we were expanding it already, but we have kind of gone on high speed when we, with the COVID-19. We've been in a phase where we have to do new trainings, and I think one of the barriers are that right now we can't go outside of Colorado, and but I know that they're looking into reciprocity of licensures, because there has to be licensures in different state and malpractice, and it's very involved, but we're hoping to expand further. And I think that really ends our presentation, but we would like to, I see there's 22 messages in the chat box. So what we'll do is read aloud the questions. But first, I really want to thank everybody for your attention to this presentation. We really appreciate you joining us today, and welcome any feedback you want to give us, because we do want to do better. I'm trying to see where we left off reading these.
I see one question about the San Luis Valley.
Yes.
We are really interested in expanding our model, and And quickly, one of the easy ways for us to do that is to include people in outreach areas, and San Luis Valley would definitely be one of them, in our ECHO. And then we are always working to expand our outreach opportunities. And I want to be clear that our outreach clinics are not to go out to people's clinic and do what we do in their clinic, do what we do here at main campus out in clinics, but rather really to provide some education and training and learn from each other how we can work together so that kids can be identified and cared for in their communities and not have to come in to Diane Schutt's campus.
So we're providing technical assistance and capacity building in a very collaborative way. And it's really been amazing to work with these wonderful providers out in different communities. I think Brian asked a question, Rebecca, that I'll let you answer about why we sometimes redirect patients who have psychiatric diagnoses to psychiatry rather than dealing with them ourselves.
Right. And I'll let Liz jump in as well, because I know this is a big area for you as well. So we really recognize that many kids come with complex issues. They may come in with dual diagnosis, or at least with a number of complex issues that interact with one another. And what we want to do is try to prioritize what we do best and send kids on to other settings for what other people might do better. And so it's the only way we really can serve the kids that really need our expertise. However, as I showed in that graph, there are a number of older kids that we recognize still need our expertise to sort out the psychological and behavioral issues. And I am incredibly proud of our team of psychologists and their ability to handle very complex patients, and really so pleased that we can partner with physicians to treat those complex kids. And I think our physicians and nurse practitioners can really provide a unique service that isn't available anywhere else. Nonetheless, what we try to do is do the best job we can to separate out the kids that need us and evaluate those kids and move them, kids that don't need us, to move on to other professionals. Liz, anything else you'd add to that?
Yeah, I mean, I think it's a really good question, because, you know, I think that I think we're pretty good at what we do. I think we have good generalist psychologists. Like, we were born that, you know, way. First we were generalist psychologists, and then from there we've really chosen to specialize in these specific areas. But that being said, given kind of what our wait lists look like and what great services are provided by our partners, like in Pediatric Mental Health Institute, which is where a lot of the patients with kind of primarily behavioral health issues are seen. You know, we want to make sure that those kids who maybe don't have kind of a primary diagnosis of developmental disability or a genetic difference or autism are really seen by the providers whose specialization is more appropriate to fit them. You know, and so I think, of course, there are many, many patients that we see that have comorbid presentations, right? So that maybe autism is present and anxiety is present and ADHD is present. And that happens a lot as well. But I think in order to really kind of serve the patients that really like we best can serve in terms of the evaluation process. And so it's not to say, oh, we don't deal with that here, but it's more to say, hey, I want to make sure that you're working with the people that really can support you in the best way. And if that's not us, we want to make sure we're making that transition.
I want to more fully answer Deborah's question too, quickly, and then Sandy, I'll let you jump in. In terms of things that parents can access, this ABCs of Behavior is a good example of, once we can get it on telehealth, it will be an easy and great resource for parents to access. Also, we're looking at different ways we can provide parent coaching through telehealth. And we have an Early Start Denver model group, for example, that's looking at some telehealth modalities for that. And then, Lila, thanks for your question about Spanish speaking. Yes, we just hired a Spanish speaking psychologist. Maritza Cobian is her name, and she will be working full-time and seeing our older Spanish speaking kids. And we also are very pleased that we have Nuri, Spanish speaking psychologist, on our team as well.
So we have 2 Spanish-speaking psychologists right now. We don't have a fluent Spanish-speaking developmental pediatrician. But what I was also going to mention with reference to psychiatric issues, our medical providers do a lot of medication management for co-occurring behavioral or psychiatric problems we treat. So we do a lot of medication management for our patients as well. Okay, so let's see, what's the next question? Are there
one about the using our family navigators for patients on the Eastern Slope? And our family navigator and 2 social workers now, and we expanded from just 1 social worker to the 3 people on this team. You know, they're working hard. And so what we prefer to do is partner with someone in that area who can ask us questions, and then we can think through what's going on, and then we could potentially have them to, you know, meet with or have a phone call with a family navigator. But we really want to partner with somebody in that area to be the go-between, so that we don't overwhelm them with phone calls. At this point, we'd love to see everybody, talk to everybody, but we, you know, we just have to be cautious about that.
So historically, our family navigator and our social worker took care of patients that we evaluated in our clinic. Now that we're doing ECHO, we provide for the primary care providers who are part of our ECHO family, we provide them with those resources too. So on our ECHO team, we have a social worker and a genetic counselor. And so if they need resources, we provide them with resources as well. So, but somebody from the outside who has no connection with us right now cannot just call our family navigator, because they just don't have the bandwidth to do that. But if somebody on the Eastern Plain want to join one of our ECHO groups, and again, it's a 6-session group that people need to commit to. We're just finishing up our 4th cohort, and it's a 6-session cohort that they're welcome to do that. And then that provider has access to our resources.
And the other thing too is our resource team is planning to do an ECHO in the fall that is for non-medical providers on resources and that kind of thing. And it would again be a collaborative process. So more to come on that, but that is one of our next steps.
Sandy, you want to talk a little bit about, I know that we're at the end of our time, but anything about the other conditions, developmental conditions in general?
In terms of who we evaluate?
So Michelle asked about FASD and other developmental disabilities.
Okay, I'm sorry, I didn't see that. So we have our physicians and our psychologists have evaluated FASD. We can't keep up with the referrals, and actually a group of our providers were going to go to Washington to do more training in FASD, and that was put on hold because of COVID-19. And so we also want to collaborate with our genetic partners. And so I think it's more of a hospital-wide issues for selected services, but we definitely do evaluate kids with FASD. It's just that we have a lot of other conditions we evaluate as well. We don't have an FASD clinic per se right now.
Not yet.
Not yet. But the part of the issue is manpower. I mean, we are short staffed. So we had 4 openings for developmental pediatricians, 3 well, somebody else just retired, but somebody retired, and this was outside the fourth, so that's a fifth person who retired. But we had people who moved away or took other type of positions, and we hired two more pediatricians, developmental pediatricians. We also hired two nurse practitioners that we needed to spend some time training them to get used to our way of evaluating and managing children. And they're wonderful. They're absolutely wonderful. So we could hire 10 developmental pediatricians and we still wouldn't be able to keep up. So we are trying to increase our manpower or woman power or whatever, but I think we really need to do more to support children within their medical home and support primary care providers so they feel like they have the tools to be able to do more. Because I think it seems like, and Liz could talk to this, they really want to be managing their own patients more.
Yeah, and I think too, instead of giving them fish, we're teaching them to fish.
Right.
Yeah, and I think the question too might have been more specific to like, are we doing a specific educational program with the PTs about like other developmental presentations? And so right now, like the PCN model that I was describing really is focused on autism specifically. I think it's a great idea to extend that to other presentations as well. But right now, that's been the main focus of that program. And the FASD question is it's a complex one, like Sandy was saying, because to diagnose it ethically and accurately, it really requires multiple components, behavioral components, and assessment components, maybe that a psychologist performs, but then really specific medical components as well, to really, not to mention a documented history of the exposure, which oftentimes is the hardest thing to get for sure. And so it's quite a complex conundrum when we are faced with these kids in clinic. And so, yes, I think we need to do more education on that. And I think right now too, we're just kind of catching up with that demand ourselves.
Yeah. And we're funded, we have some funding for this project. Before this project began, there was a needs assessment throughout the state that somebody from the health department and Angie Gujar and David Keller from Children's went around the state to do a needs assessment. And the number one need were assessments and management of children with autism. So we actually applied for funding to address that need specifically. And so the ECHO and some of the other care pathways were really funded with that purpose in mind.
In terms of expansion to Pueblo, we are excited, as Sandy had mentioned, to build another clinic in Colorado Springs so that we can be more accessible for families in Pueblo. But also, we are very aware that the Eastern Plains and the southeastern part of the state, when we look at our wait lists, there is a significant number of patients on our wait list that are Colorado Springs and South and Southeast. So we're very aware of that. We definitely want to get to you in the Pueblo area, and we are very aware of that. So we're working on it. Anne, you want to talk about the stat?
Yeah, so speech therapists can be trained to do the stat, absolutely. The Vanderbilt is where you might go to get training. They have online training, and they also have the opportunity to send some of your videos of administration to them. So yes, a speech therapist can be trained to do the stat.
I think Linda had some questions about children who've already been diagnosed with autism that may need to be reevaluated. And so we do see lots of reevaluations in our clinic. And I think that's one of the things that perhaps can get addressed in an initial assessment model, right? So if this is a patient or a family coming in that needs a reevaluation, looking at the evaluation, talking with the family about the needs. I think, are you guys still hearing me okay? Because
Yeah,
I'm seeing,
okay.
okay. There's something coming up saying I was unstable. I think
That's a whole nother problem, Liz.
yeah, I know. Maybe we don't get into that. But I think sometimes what we see are multiple requests for reevaluations, like 2 or 3 times. And so those are things that we are hoping that we can talk with the families about, and hopefully not be caught in a cycle where we're doing that more times than we really need to. But usually kids who need a reevaluation, and Rebecca, maybe you need to correct me on this, but there's not a different pathway in terms of their referral process or wait.
There's not, but I think one of the points that Linda is making that is somewhat helpful is sometimes it's not a full reevaluation that's needed. There are other providers that can get involved, such as occupational therapy, speech therapy, and that's our integrated services across the hospital. We recognize that we really can partner in care for children with autism, and it doesn't have to always be developmental peds doing the work. So for example, sometimes a child will come back for a reevaluation of autism, and the real concern is we really haven't provided good sensory integration approaches, or maybe we don't have good speech therapy helping the child to communicate, and so by involving speech therapy we can do a better job managing tantrums because the kid's less frustrated. You can imagine everybody on this webinar understands the way that we can use interdisciplinary care to improve care. We are developing an approach within developmental peds where we try to prioritize kids that really need a reevaluation. So these are the kids that are involved in medical care, and our physicians need more information to continue to provide their medical care. That's just an example. There's many different examples of kids that we want to prioritize in terms of their reevaluation.
So Dina posted a question asking if Michelle Butler's query was fully answered. She asked, what assessments do you plan to use for initial ASD evaluations within telehealth? So
we jumped in and talked about that a little bit. We are trying to optimize the standardized assessments that we can use in telehealth. And there are a number of them that we can send electronic versions of assessments to families. Actually, there's a lot of our assessment that we can give through telehealth. Technically, we can give through telehealth. But when we're working with the kids we love to work with, telehealth is not always the best modality for doing our psychology assessments. So we're looking at more innovative models of how we can do it. As Anne mentioned, doing some kind of parent-assisted assessment for autism, and there's been a number of efforts in that across the nation, really, to look at standardized ways to do telehealth assessments. But what we want to start with are the things that we feel very comfortable are standard of care for assessment of autism. And as COVID goes on longer, we may have to look at increasingly more innovative approaches for our assessment models. So I hope I answered that.
To answer Linda's number 2 question, the new intake model, that hospital-wide coordination of care for autism model, they'll have intake with social workers, family navigators, and they will absolutely direct them to OT, speech, PT, early intervention, schools, while they're on the wait list. Absolutely.
And then Linda asked one more question as approximately how long after the initial diagnosis should a child be reevaluated?
I'll answer this because it's controversial. So I think a short answer to this is that a lot of diagnoses of autism really don't need a reevaluation to confirm later on that the diagnosis is still present. We believe for most of our patients, this is a lifelong presentation. I think when we see questions for reevaluation, it's to really consider, is this the correct diagnosis? Or, you know, after specific intervention, is this individual still kind of meeting criteria, behavioral criteria for the diagnosis? But I don't think it's a common practice that this is a diagnosis that needs to be reconfirmed throughout the lifetime. you guys want
I
to?
think, yeah, I think that the main area where I see it used is kids who had an eval when they were 3 or 4, and their cognitive testing is not necessarily, they weren't as socially motivated at that point. And so in planning for adulthood, secondary education, things like that, we would sometimes bring them back in to do cognitive testing and adaptive testing. And that's usually, in mid-teens and preferably well before 18.
The other thing we've identified is families or kids that need specific assessment to continue their ABA, or insurance is asking for specific assessments to kind of continue under a diagnostic consideration. And we are doing our very best to triage those appropriately. So again, not every kid gets a full evaluation, when what we really needed was a focus adaptive measure. This is complicated. And so one of the reasons why we are so grateful to have a new resource team to help us do some of this initial intake is they can help us identify what's really needed. Sometimes families think, oh, I need a full evaluation. And then when we talk to them, we need something more focused. So we're doing our best.
And sometimes there's a dramatic change. Sometimes we see kids who have a regression and we don't really know, the parent feels like there's a loss of skills, but we need to document, was there really a loss of skills? And if so, the child probably needs some type of medical workup, and also looking at psychosocial factors. So it really depends on the presenting question.
Yeah, I think the point about updated cognitive testing and adaptive testing is really, really important. Because again, all of our patients are on their own unique developmental trajectory, but kind of broadly speaking, like something like IQ scores, we don't really think are solid until a kid's maybe 8, 9, 10 years old. And so a lot of times if we're seeing a kid in an early stage in their life, and we're doing maybe developmental testing to get an idea of what their skills look like compared to other kids their age, it may be really, really informative for us later on when they're older to then do standardized cognitive testing, so we can see again what their kind of innate ability to problem solve and kind of process information looks like, because it informs IEPs and other kind of supports that may be put in place for them.
Yeah, and there can be kind of, these rules fluctuate, but right now you need an adaptive measure to get on the adult services wait list, and that's at 14.
I think if I would have our audience come away with anything, it is that we are trying to be more flexible, more innovative, that we are not just locked into kind of one standard of approaching our families, and that we really are trying to take into consideration our patients and what they actually need. And so, and I'm sure that everybody else wants to jump in on this too, but it is the case, generally speaking, that medical assessment, so kind of assessments we've been talking about, open different kinds of resources than a school-based identification does alone. The school-based identification of autism tends to open up very important educational resources, and we're very grateful for our partners in the educational community for providing those services. But for insurance and some ABA services, you need something in addition to school-based diagnosis.
And that's where our initial assessments can be helpful. If a child already has a school-based diagnosis, then sometimes we need a shorter appointment just to confirm that we feel like it's accurate.
Mm-hmm. That's a good point.
So Michelle made a point a while ago, and I don't want her to feel like we're ignoring her. But so I just wanted to move backwards a little bit, where she said that there's more kids with fetal alcohol spectrum disorder than autism, but we don't have enough resources for diagnosis and treatment. So there are a lot of children with FASD, without a doubt. Our medical providers could do an assessment, do a good prenatal, perinatal, postnatal history, family medical history, social history, physical exam, do measurements and look at growth parameters. But a lot of time, what's has happened, a lot of these kids go for individual consultations with our psychologists. And I think we realize that our psychologists, it's much better to have a team approach, as Liz had said, to do the medical aspect of it, and as well as the psychological assessment as well. They have to go hand in hand. The issue is capacity, and while we see kids with FASD, that hasn't been our big thrust. We acknowledge the need, and we have talked to genetics about it. Where should these kids go? Should there be some type of a collaborative program? We just haven't had the bandwidth to expand what we're doing, although we acknowledge it's a need, and we would like to be able to provide that service more to the community, but it's really a capacity thing right now. But it has been discussed a number of times within our group, so we're not making light of it. But that's not where everybody in our group's expertise is. I would say all our providers have expertise in assessing autism, developmental disorders, co-occurring behavioral and psychological psychiatric issues related to developmental disability and autism, but everybody doesn't have the same type of expertise in FASD. That's not for want of having that. It's just, that's where we're at right now. Okay. Did we go through all the questions? I just wanted to see.
Any other questions or
Great
confusion?
questions. Sorry, I was just saying these are great questions.
You really are.
Yeah.
I think we've gone through everything. And if we've missed you, please put a little note that we should go back and look at your note. I think we've gone through everything.
I would add that if you're interested in participating in our ECHO, please reach out to us so we can send you the invite. We are looking at, so our ECHO includes, and you guys can help me out if I miss anything, we talk about behavior, we talk about anxiety, we talk about ADHD, we talk about medication.
Medical workup.
Medical workup. What else am I missing?
Sleep. Did you do sleep?
Oh yeah, sleep and toileting.
And although in the next session, we're thinking about shaking it up a bit, because we may add or subtract certain topics, but they're all relevant and there's a lot of discussion. So if somebody has a question unrelated to the little presentations we give, they're just welcome to present whatever they want. So I don't think we have any more questions. So I truly want to thank everybody for participating and for listening to us and for your great questions. And please let us know if we could be a resource for you. So thank you very much for your attention to the presentation.
Thank you all.
Thank you.
Thank you.
Bye.